Hi, good morning. Morning, everybody. Let's get this started. Welcome to today's evidence-based health policy project briefing titled Addressing Opioid Use, What's New and Emerging in Wisconsin. I'm Sam Austin, the EBHPP Project Director. Thank you all for joining us today, and to all our panelists up here on the podium. Before I get started, I'd like to briefly introduce the evidence-based health policy project. The broad goal of this project is to connect research and expertise at the university and elsewhere into the health policy-making process here at the Capitol and support evidence-informed decision-making broadly. This goal is driven by the idea that ongoing dialogue between policymakers and academic researchers and the development of trust can enhance and elevate the work of both. We work to serve as a resource at the Capitol and a resource on campus through the convening of nonpartisan, high-quality briefings such as this one, and facilitating interaction between the legislature and the university in many different forms. The project is a unique and formal partnership between the University of Wisconsin Population Health Institute, where I'm housed, the La Follette School of Public Affairs at UW-Madison, and the Wisconsin Legislative Council. I'd like to recognize Hillary Shager from La Follette and Steve McCarthy from Ledge Council, who are project partners and play an integral role in making this project successful. Thanks also to Rochelle Andre, project assistant. Well, that's a surprise. This was completely planned. And we will just keep pushing through it. We'll see how it goes, all right? If we are told to run out into the Capitol lawn, we'll all run out there together. This project is made possible by the support of our funders, including the Wisconsin Partnership Program at the UW School of Medicine and Public Health, Community Academic Partnerships Core at the UW Institute for Clinical and Translational Research, also known as ICTR-CAP, and the UW-Madison Chancellor's Office. We thank them for making this event possible. Develop these events with the input from our Legislative Advisory Board, a bipartisan group of legislators representing a range of perspectives on health issues. Our current board membership includes Representatives Joe Sanfilippo, Deb Kolste, Daniel Reamer, Jesse Rodriguez, Joan Ballweg, and Paul Tittle, as well as Senators Devin Lemieux, Mark Miller, and Leah Vukmir. We truly appreciate the engagement of all those offices on the project and also legislators who are in attendance today. And it seems like we may be okay to stick here for a little while longer. All right. Your folders that you received upon entering have several documents inside today's agenda, biographies of our speakers, and a list of further resources. Also 2 handouts giving an overview of the EBHPP and the UW Population Health Institute. And finally, you'll see a pink evaluation form that we hope you'll take a minute to fill out. We aim to be as responsive as possible to both legislator interests and also the interests of the audience that attend our briefings. We can't do that without your feedback. You'll see that the event is being covered both by Wisconsin Eye and the UW Extension Instructional Communication Services. Video of this event and all materials will be posted online in the days following the briefing. And if those of you following along in the room or online want to participate in the dialogue on Twitter, use hashtag EBHPP to join in the discussion. This event is the first of what we hope will be an ongoing series of what we're calling EBHPP Research Roundtables, which will be set up as brown bag briefings highlighting current university research and work on a particular topic or from a particular school. The original idea for this series was to plan for smaller audiences than the traditional EBHPP Capitol briefing. As you can see by the number of people in the room, we sort of missed the mark on the small audience bit. But it's good that we have a big audience because today we're talking about a big issue, an issue that affects our friends, our neighbors, and our families all across Wisconsin. Recently released data from the Wisconsin Department of Health Services indicate that over the past decade, the rate of opioid overdose deaths in Wisconsin has nearly doubled. The rate of hospital visits involving acute opioid poisoning has also doubled. And the rate of neonatal abstinence syndrome, where babies are born with withdrawal symptoms, has quadrupled. This is a problem that has arisen from many causes and will require many actors working together to solve. These actors include the state legislature, which is currently working in special session on bills to further the HOPE agenda, the executive branch, which has recently convened the Governor's Task Force on Opioid Abuse, community-based and private sector organizations, many of which are represented in the room today, and in addition, research and work by the University of Wisconsin and other academic institutions plays a vital role in informing the work of all of those actors and enabling them to enact policies that will address this problem in the most effective way possible and ensuring the policymakers aren't flying blind regarding what works to address this epidemic. Today's panel will highlight several current projects. Alexander Zagierska and Captain Corey Nelson will discuss smart police initiatives, and Dr. Zagierska will also present on mind-body approaches to chronic pain management. Sarah Lindberg will highlight evaluations on opioid-related programs in communities across the state. And Bree Dio will talk about a current study to screen for opioid misuse following a traumatic injury. We hope that opening a window on this ongoing work with community partners in the UW will complement the legislature's work in the special session and strengthen connections between the campus and the Capitol on this issue. Our first speakers are Alexander Zagierska and Corey Nelson. Dr. Zagierska is a professor at the UW School of Medicine and Public Health's Department of Family Medicine and Community Health. She provides primary and addiction medicine care at UW Health, and her research focuses on improving outcomes in patients with substance use disorders and opioid treatment chronic pain. Captain Nelson has been with the Madison Police Department for 28 years and is currently the commander of the West District. He was the primary push for applying for federal funds to divert low-level property crime offenders into treatment, a project now known as the Madison Addiction Recovery Initiative. After each of today's presenters, we have a brief Q&A session, either for legislators at their seats. We also have a wireless mic for probably 1 or 2 questions, given the time frame we have. And with that, Dr. Zagierska, Captain Nelson, thanks for being here, and take it away.
Thank you for having us. So I guess I should go to my slides here. So we wanted to talk briefly today about initiatives we've been engaged in that aim to reduce opioid-related harms and improve outcomes in both addiction but also chronic pain, because as you know, these two conditions are highly overlapping. So why do we talk about overdose deaths? We all know what a big problem it is, but it is stunning to me to see those numbers, how often overdose death happens in the U.S. When we look at all drugs and all causes, it's about every 9 to 10 minutes. So if my math is correct, it would be about 8 or so overdose deaths during this meeting today. If we look just at opioids, 1 overdose death happens every 16 minutes, so about quarterly in the U.S., and this is according to the 2015 data. Unfortunately, we are expecting that both in Wisconsin and nationwide, the rates of overdose deaths are not decreasing. So this slide here just shows Wisconsin, both Dane County and the state, through 2015, based on what we see in terms of naloxone use in 2016 and this early 2017. These numbers are not coming down. So what should we do? This data is pretty grim, and as listening to patients, but also as a clinician and as a mother and a member of our community, I often feel full of despair on the surface. Just like this individual in this famous painting. However, the good news is that there are ways and effective treatments to address addiction, particularly opioid addiction. So we are here to talk about 2 initiatives we've been involved in, and over time, somehow these 2 initiatives have been merging because a variety of meetings we've been engaged in, we are going there together, and then we are talking about 2 studies. So Captain Nelson is well versed in my research on mind-body therapies for opioid-treated chronic pain as well. I'm the principal investigator on a grant funded from the federal agency, Patient-Centered Outcomes Research Institute. This is a large grant that required multi-center, multi-geographical site collaborations. So this will be done with University of Wisconsin as a leading site, but also with Harvard University's Brigham and Women's Hospital and University of Utah in Salt Lake City. So we are trying to geographically span across the U.S. We are looking at patients with chronic lower back pain. And it's important to note that chronic lower back pain is the main cause for opioid prescribing for non-cancer pain. So this is important target population. We are going to enroll patients and recruit patients who receive certain minimum dose of opioids per day, every day. We are going to randomly assign these participants into 2 safe therapies that have shown promise or evidence-based, depending on which one we are looking at, for the treatment of chronic pain. However, there haven't been studies looking at opioid dose reduction with these therapies, so that's the new addition to the body of research evidence. The study, much smaller scale, that we conducted here in Madison shows that patients on average, after mindfulness meditation training, those who failed essentially all other treatments and are on opioids, they on average reduced about 300 milligrams of morphine equivalent per month after going through this brief 8-week training. So it holds promise. We also know from a more just broader research that both therapies, they train the mind to change our responses, not just to pain, but that's the main target, but to other challenges that we are facing in everyday life. And research shows that these changes are not just regarding function of the brain, but there are also structural changes after those kind of trainings. So we anticipate, not just hope, to see that after we follow up these patients for 12 months, we are hoping to see reduced pain, improved function, improved quality of life, and as I mentioned, reduced reliance on opioids. So what can you do as a group of people? Spread the word. We will be recruiting patients starting in June or July, so we would like to reach out across Madison, and are working with all health systems across Madison. We also, one of the goals, why are we studying it, is to make these treatments later, after they are hopefully proven as really evidence-based effective therapies, to have them well covered on par with medications by health plans. Because currently I can prescribe opioid medications to any patient without any problems. However, if I order psychological treatment, it's not as easily accessible for patients. So our second initiative that I wanted to briefly outline is done jointly with the City of Madison Police Department, and as it was mentioned, Captain Nelson was the primary developer of the idea based on what we've seen in other cities. And this initiative aims at removing stereotypes from the disease of addiction and improve access to treatment for those affected by addiction. Because as we probably all experienced, when the word addiction or a person with addiction is mentioned, there are a variety of images, those stereotyped images that come to mind of those people, or poor people in dilapidated places, or people who are passed out on the street. In the past, it was mostly a person who was drunk. Currently, these are individuals who overdosed, and police officers respond. The response to overdose is one of the main reasons for their response in the field. But again, these are stereotypes, because as we discovered with opioid addiction, addiction can affect anyone. Could be me, could be you, it could be any of our family members, our children, our spouses. And that's why it's really important to work together to change these stereotypes and help individuals get treatment that they need. This initiative started on example from other places in other cities that later Captain Nelson can mention that have shown that police-led initiatives can lead to dramatic changes in the landscape of substance use disorders. They can lead, when we replace arrests with treatment, they can lead to reduced substance use disorder issues, reduced overdose deaths, and reduced crime in the community. So with this in mind, we proposed and then got funded through the U.S. Department of Justice to conduct a project that would not only link individuals who committed minor drug-related crime to treatment, but also we would ensure that we carefully track outcomes so we can show later on paper, in quotes, and with numbers, whether this initiative is successful. So currently, the MARI project, or Madison Addiction Recovery Initiative, will allow individuals who commit this low-level drug-related crime to be offered either treatment or pressing charges with jail time, which we expect that majority of people will choose treatment based on not just our expectations, but experience from other places. The grant funds will cover the salary of a full-time counselor who will provide assessments in a centralized location. What will this approach allow us to do is we'll be able to have one card with one phone number and one location to help individuals get to this one spot. Currently, a lot of people, especially when they are struggling with addiction, they are lost. They don't know where to go, which treatment places are covered by their insurance plans. So we believe that this centralized assessment will make a dramatic improvement in the processes and access to treatment. Based on the counselor assessment, a given individual will be then referred to appropriate treatment, whether it's a detox, residential treatment, or outpatient treatment. This part, though, is not covered. The treatment portion is not covered by our grant, so this will be one of the areas that we are looking for support and help from the community and collaborating health systems and health plans. And what are the benefits? Except the obvious one that an individual will have his or her disease of addiction addressed, this individual will also avoid criminal charges after they successfully complete the 6-month requirements of the program. And as you know, lack of criminal record means easier or possible search for job as well as for housing. We will allow community access. So as you can see on the left side there of this slide, there are emergency services, medical providers, community providers, or self-referrals. But so we'll keep our door through the centralized assessment open to all, realizing that if the program is wildly successful and the need is really huge, as we think there is, we might not have the capacity to see everybody, but we'll start with tracking of data and monitoring how the progress of this project. We also will have recovery coaches engaged in this process, and we are collaborating with local treatment programs on this aspect to both have a contract for counselor time and for recovery coaches services, so that individuals referred to the hub can make it to the hub, but also make it to treatment with the help of recovery coaches. This is a very busy slide. I don't expect you to read through it, nor I will go in detail through it. But as I mentioned, we are hoping to see individually improved outcomes. The individuals who go through the MARI program we are hypothesizing they will have fewer overdoses going forward, fewer repeated offenses, and in general crime. And the same we are hoping to see on the community level, because our main measure of success are community outcomes. So we are aiming at reduced overdoses, reduced healthcare utilization, and of note, our initial estimates based on claims data from ED and hospital admissions show that one overdose costs on average around $50,000. And when you multiply it by over 800 overdoses we had last year in Wisconsin, these are stunning numbers. We're also hoping to see less crime and, of course, less active addiction and its correlates like HIV or hepatitis C infections. We are also hoping to see change and improved police practices as well as police relations, and Captain Nelson can comment on it. We just started the grant recently, although we've been working on it for over a year and meeting regularly with core group of investigators and supporters, as well as with a larger stakeholder group. But the formal funding started recently, and we are planning to start assessment with referral to treatment services in June this year. These are the members of the core group, which spans Madison Police Department, UW, Madison Public Health Department, Dane County Human Services, Safe Communities, and WEA Trust. We didn't add here on this list, which probably we should, apologies, the DA's office. So we've worked closely with the DA's office to make sure that we are not unilaterally making those decisions which crimes can be considered for diversion versus not. And this is our larger support group, and I'll pass the mic to Captain Nelson.
Thanks, Doctor. I see Mari from Public Health walked in. She deserves a ton of credit for all the work that she's done in this program. They've been a very valuable partner with us. We are fortunate to partner with UW-Wisconsin with Dr. Zagurska. She brings the expertise to the table, which none of us in policing have. So for 28 years, I've seen drugs come and go in the streets of Madison. I've dealt with dealers. I've dealt with users, addicts. I've never in my life seen what's going on with heroin currently. People are dropping dead. People don't drop dead of cocaine, of marijuana, of crack, of meth. You know, those are long-term killers, but people are dropping dead of heroin. Last year, we had 440 overdoses just in the Madison area alone. Our numbers are skyrocketing. Every year, they're going up between 75 and 100%. I've sat in parent addiction network meetings where I've heard parents tell stories of children who have died while sitting on a waiting list waiting for heroin treatment. Absolutely unacceptable. So things have to change. We are fortunate enough, as you can see on that slide, to have partnered with a number of agencies in the city and the county, and we can move mountains with this group of people and communities and agencies. There's a lot of things we can get done. There's a lot of change that needs to be done. We need to increase quicker access to treatment. That's a problem. There's currently up to a 90 to 120-day wait, depending on providers. So law enforcement traditionally treats addiction as a crime. When someone overdoses, they are basically either issued a citation or taken to jail. Possession of heroin is a felony. But we're seeing this not working. Our skyrocketing overdoses every year prove to us that what we're doing is not working. So it's time for us as law enforcement to start looking at addiction more as a disease, working with our partners in the disease, the experts in disease with UW and with the public agencies, and to try to get these individuals treatment rather than stigmatizing them the rest of their life with a felony conviction for a crime of addiction. If anyone is interested in assisting us in this project, please get a hold of Dr. Zagurska or I or after this, and we'll exchange numbers. But we do have a larger group that's working on legislative type issues, different bills and such. So we are excited about what we can do. Like I said, the more people involved, the more things we can get done.
And in terms of what can you do to support not just this project, because our goal is not to satisfy the conditions of the funded project. Our goal is to create a program that is sustainable and functions well in this area for years to come. That's why we've been working diligently on the front end to form coalitions and talk and pull in people from a variety of organizations. But our larger stakeholder group that includes, as we're showing here, multiple organizations and community service groups, what everybody is bringing up is we need to improve access to treatment, and we can't easily do it without working on workforce development, because we do have shortages of providers, shortages in funding for the treatment of addiction, and excuse me. And so this will be one of the crucial elements that cannot be changed without broader support from all groups working on it. In terms of legislative changes, there are a variety of options. We, based on the feedback from the larger group, put here on the slides only 3, but there are many more opportunities, and the upcoming and past HOPE laws have shown of tremendous help to allowing people access treatment and for this disease. Cocaine Mom Law, which is the Wisconsin Act 292, is one of the laws that is believed by all medical societies to deter pregnant women from care. This is the law that allows medical providers, whether it's a unit clerk or a physician, to report a pregnant woman who is using drugs, and not surprisingly, as an outcome, women are scared seeking care when they are pregnant, and that's the time when they should be seeking care, and that's the time when they really want to receive care for addiction. The other one is the regulation, DHS Regulation 75, that we are working now as a part of this program, the collateral work that we haven't anticipated going into it, the regulation that says that each of the treatment centers is supposed to have their own independent assessment process, which doesn't make sense, because if a given person within a month has to go through several agencies because one treatment may not be covered and they are sent somewhere else, the same assessment with a wait list for that assessment is repeated multiple times. So this is one area that we are working on to make changes so that one assessment, if done professionally and according to the standards put forward by the DHS, can function across institutions. And then finally, ensuring that medication-assisted treatments as well as other treatments for addiction there is continuity of coverage. So if there is no insurance coverage, the patient can't typically afford treatment. What we see currently is that those who are successful in recovery and, for example, find a job, their income might be suddenly too high to be eligible for continued Badger Care coverage. They drop off their insurance because they started working and they can't afford treatment, with the outcome of relapse. Another area is looking at different models of Medicaid coverage. For example, Minnesota provides this grace period for people to ensure that they will not be taken off their insurance. Another area is Medicaid not covering currently injection fees if the injection was delivered in the pharmacy, which is a small yet a stumbling block for administration of Vivitrol by pharmacists, as we are working on this issue across the state. So this is where we would like to pause. There are a variety of ways how these projects could be supported by broader community, but also how they can add to the broader community's health. And if we have time, I'd like to open it for questions.
We'll have time for a couple questions, either from legislators seated up front, and there'll also be a wireless microphone walking around if we have time for a couple audience questions. And we'll start over here. Senator Bewley.
Thank you, Senator Janet Bewley. Thanks so much for this excellent presentation. I have a question regarding LEAD, the Seattle program, the law enforcement diversion. Knowing that the biggest obstacle right now is the lack of treatment, would you anticipate that some services, harm reduction services, could be provided before sobriety while people are still using, since we just don't have enough access to treatment programs?
So we have resources to provide treatment. We don't know whether we have enough, but it's not that we don't have treatment, especially in Madison area. One of the problems we've seen is that it's fragmented healthcare delivery in the field of addiction, so patients really don't know where to go. And there are treatment providers the health systems and patients may not even be aware of. So one of the areas of our work done by Safe Communities is to map out what are all pockets of treatment, and there are numerous. So we tried to put it on slides and to present here for this group, which was impossible because the slides just showing where are the providers covered by given health plan. Those slides were like 20 slides, which means the patient is really lost. So we are hoping that when we know what we are doing, when and where we are referring the patient, this will already help them access treatment.
But what about in rural areas where?
So there are different models that we also are looking at. So first of all, the MARI program is here in Madison, but yes, we are looking also, and we are aware that this program is looked at as a possible type of program that could be spread across Wisconsin. So we are also working currently with pharmacies and pharmacists and telemedicine providers on a potential delivery of treatment services for addiction via telemedicine and involvement of primary care providers and pharmacists as part of the treatment team. But in general, we are working with shortages of providers, as we know, so it would be fantastic to have more providers and more trained primary care clinicians.
But prior, again, I don't mean to take up everyone, but there is the model of harm reduction in assisting users to prevent crime and overdose, like what they're doing in Seattle. Do you think that is a valid approach?
Yes. The simple answer is yes. Our program doesn't focus specifically on it, but by linking individuals with peer recovery coaches, we are hoping to carry them and help them make it to treatment. So this initial period, it is harm reduction approach. And we actually, and this was a heated debate about nuances, what does it mean to successfully complete the program? I avoided stating successfully completed treatment because, first of all, treatment for addiction does not last 6 months. It lasts years, ideally. So it successfully meet the requirements. So this is also the harm reduction approach. They may not be perfect at 6 months, but if they are on a good trajectory and do not reoffend, their charges will be wiped out.
And we looked at programs around the country. We're not replicating a specific program. We're trying to figure out what best fits for Madison, because this is, at this point, just a Madison idea. The SPI initiative, the idea behind it is to see if this is a successful program, and if it is, to try to replicate it across the country in other jurisdictions.
Hi there, Representative Subek from Madison, up the street from the West Police Station. I'm curious to hear more about who the target population is in the MARI program. What types of offenses? Is it typically first offenders, multiple offenders? Sort of who is it that's being targeted or you expect to have success with?
Sure. We're going to target individuals who are committing retail theft, individuals who are committing theft from autos, prostitution, overdose would be the primary targets, more or less victimless crimes, familial related burglary. Believe it or not, a lot of people break into their grandparents' homes or parents' homes and steal money to support their opiate addiction. Cases like that in which they don't want charges pressed against a family member, they would be offered this as well. Target population, again, is, like the doctor mentioned earlier, is that heroin doesn't discriminate. It's all ages, races, sex, income levels, rich people, poor people. It's all over. Just the other day, an extremely wealthy person, well noted in the community, just died of a heroin overdose. So it's not something that's restricted to the lower income neighborhoods.
Just quickly to extend, when I talked about target population, I always get what crimes, but also first offenders, multiple offenders, things like that. Is there a pattern that needs to be seen first?
Sure. It would be mainly first offenders. Individuals with repeated acts would not be considered. Individuals on probation are not considered. Individuals on bail are not considered. There are programs out there. There's drug court out there that addresses those individuals. This is not meant to replace any of the programs that are currently in place. This program is different in that all the other programs, an arrest occurs, and once an arrest occurs, a criminal record is started. In this program, the arrest does not occur, so therefore the criminal record does not start.
And actually, we're trying to squeeze a lot into the time we have. If there are any further questions for the panel, we can send those along, and I apologize for the tight time frame we have. Thanks again to both of you for your presentation. I'll send the clicker down this way. Our next speaker is, our next speaker is Sarah Lindberg, Director of the Evaluation Research Group at the University of Wisconsin-Madison Population Health Institute. She leads a team of over 40 professional evaluators. She's a psychologist and epidemiologist by training and specializes in evaluating interventions to improve community health and promote health equity. Dr. Lindberg, thanks for being here today, and go ahead.
Thanks, Sam. It's a pleasure to be here. My talk today will be a little bit different from the others in the sense that I won't be talking about a specific program, but rather will be giving you a broad overview of a variety of work that's happening across Wisconsin and the role that evaluators play in that work. As Sam mentioned, I work at the Population Health Institute at UW. where we have a team of folks who are dedicated to program evaluation. And I'll be, just to set the stage for the opiate work that I'll be discussing, I'll be starting with a little bit of that context and what evaluators do and why it is that we're involved in such a broad array of programs around this topic and others. So why evaluation? I think Dr. Zagierska sort of set some of this up in the sense that, when you're implementing a program, you really want to have a sense of what the needs are, what's already out there. You want to sort of set that vision of what the program is intended to achieve, to outline some benchmarks toward that, what kind of activities will be implemented, what the expected outcomes are, and so forth. And what evaluation does is to take a systematic look at a program or a policy in order to understand adherence to that vision. And so we set forth at the beginning some evaluation questions and then really work to systematically document the program activities, the program processes, the outcomes, both intended and unanticipated of various programs. Another key component of what we do is to foster ongoing learning and quality improvement. And so very often during the course of implementation, you discover that in fact things can't be implemented as the original vision had intended, and certain adaptations are needed. And so we try to document that and what adaptations are needed, what challenges are arising, what are some of the unanticipated consequences, and is there learning and improvement that can be happening over time to ensure that programs are as efficient and effective as possible. Another thing I'll highlight is that one way that evaluation is a little bit different from research is that it is very specific and applied. And so we are not, as a rule, trying to contribute to generalizable knowledge, but we're really trying to figure out specific questions for a specific program for a specific purpose. And so we want to know, we're collecting data that are intended to be useful, and we want to answer questions that people are interested in and really make sure that the evaluation data are useful in that decision-making process in order to really improve programs and practices. So what does evaluation look like? The answer is that it really varies. And evaluators, as a general rule, our team are really strong methodologists. And so we know a lot about a variety of evaluation techniques, including a whole range of things, from qualitative interviews and focus groups and really descriptive work, looking at documents that already exist and sort of coding those to make sense out of what exists and what's known. On the other end of the spectrum, there's a lot of very targeted evaluation research, and so you might see things that are experimental designs and randomization, and it really just depends on the questions that are being asked and the knowledge, or what answers you're really looking to answer, or what questions you're looking to answer. So as a general rule, our team of evaluators are really skilled methodologists. In addition to that, we do have folks who have over time developed a lot of really deep content expertise. And so I would not claim to be a content expert in addiction, but we do have a few folks who have worked in substance abuse prevention and treatment for decades, and that experience has lent itself to substantial expertise in this area. So with that in mind, I'll be talking a little more generally about the kind of work we do and some of the programs, but I cannot necessarily speak in depth to some of the specifics. So one of the things that I want to highlight is really just the expanse of the work that's happening in Wisconsin. This map highlights programs that our Population Health Institute evaluation team is involved in across Wisconsin, and highlighted in red on the map are programs where there are specific local touches and partners. And you can see certainly we're touching some of the urban areas in Wisconsin, but also many of the rural areas as well, and really targeting a variety of populations. In addition to these specific local programs, we work with a number of programs that are really aimed at statewide impact. And so even for those who live in areas that are not highlighted in red, there are likely to be touches from the different types of programs and work that are happening around opioid addiction. I've also highlighted the investments that are being made at the national and state levels in this work. Considerable amounts of funding are now being put toward this, and our specific funding to do this evaluation work is provided by entities like the National Institutes of Health, the Centers for Disease Control and Prevention, the Substance Abuse Mental Health Services Administration, the Department of Justice, and the work is really conducted in collaboration with many partners at the state and local level. And so that theme of partnership will be something that you'll see as I go through the next two slides, because in fact there are just many people working in these areas and are sort of collaborating to make a difference. The work that we do really spans the whole spectrum of addiction, and all the way from prevention, where we are really working to keep people from becoming addicted in the first place, to treatment, where the goal is really to get folks who are addicted into treatment and into recovery, as well as to mitigate harms, as you mentioned, as well as diversion, right? And so making sure that for those who are interfacing with the criminal justice system, that the outcome might be something other than imprisonment, if in fact there's really a substance abuse addiction at the root, rather than a criminal, sort of that criminalization of addiction. And so then I'll just go through in a little bit more detail, just to give an overview of some of the kinds of programs that we're touching in each of those areas. Prevention programs that we're working with currently include collaboration with the State Epidemiological Outcomes Work Group for Alcohol and Other Drug Abuse. I know that's a mouthful. It's a bunch of folks who are really interested in data and statistics around alcohol and other drug abuse, including opioid work. I imagine many of the statistics that Sam cited at the very beginning of the briefing are a product of some of the folks on that team, and it's really meant to be a collaboration across agencies to share data and present a current picture of what's going on in Wisconsin with respect to levels of addiction and risk factors that play into that. We're working with an enhanced state opioid overdose surveillance system, in which the goal is to look at prescribing and link that to hospitalizations to identify sort of undiagnosed cases of unintentional opioid overdose, and to sort of to use that data in a way that's responsive. We're working with some programs that are prescription drug overdose prevention for states, and then there's a supplemental grant. These are really coalition-based models where we're supporting coalitions in implementing evidence-based strategies in a variety of communities and evaluating those. And likewise, the same is true for the Strategic Prevention Framework Partnership for Success. And again, lots of partners in this work, including state agencies, local governments, healthcare providers, law enforcement, and community coalitions. Some of the specific strategies implemented, including broad things like public outreach and education around the issue, but also targeted trainings for law enforcement, for healthcare providers, and for educators to look at what can be done in each of those specific settings and roles to address and prevent addiction. As I mentioned, there's work around increased data and improved data access for local communities. There's a specific interest in really local data, and so that's a need that folks are really working to address. And again, looking at monitoring and improving opioid prescribing practices, expanding the collection of expired and excess medications, and to enforce diversion of prescription drug medication. Treatment programs that we're working with include both programs that are really working to get folks into recovery, things like medicated assisted treatment, which Dr. Zaberga mentioned, or Zagurska rather, mentioned earlier, giving folks access to Vivitrol and Suboxone and other medications to help them quit and get them into recovery. Working with high school students who are addicted and evaluating the effectiveness of recovery high schools, which are a special environment, the goal of the recovery high schools is to get folks out of the environments that got them addicted into the first place, and they combine treatment along with typical educational training, and basically the work is evaluating the effectiveness of that as a technique for keeping kids in recovery, as well as really harm mitigation techniques and expanding the use and availability of naloxone to keep folks who are overdosing from dying. Again, lots of partners, state and local agencies, prescribers, healthcare providers, and educators, and with the goals of expanding screening, brief intervention, and referral to treatment, which Bree will be talking about in a moment, to increase the availability of new drugs that help addicts quit, to increase distribution of naloxone, as I mentioned, and to continue treatment and keep young addicts out of relapse. And then a final category of work that we're involved in have to do with these diversion programs, which are similar to, although maybe a little bit different from, in some ways, the work that Captain Nelson spoke about, where the goal is, there are a variety of drug courts and other diversion projects that are working to keep selected folks who are interacting with the criminal justice system out of prison and instead get them into treatment. And here we're partnering with state agencies, tribal governments, local governments, law enforcement, and healthcare providers. And the goal really is to keep folks out of the criminal justice system, if it makes sense. Before we take questions, I have a few final thoughts that I just want to sort of summarize some of the thoughts that I shared. One is that I really hope you took away a little bit better understanding of evaluation and the role that it plays in opioid work as well as other kinds of work around the state, why it's useful to these programs, and the value it has for informing practice and policy. A second point I'd like to make is just to draw attention again to the number of partners who are working in this area. Certainly there are agencies and individuals who have extensive experience and expertise in this and other areas. And this opioid work is just part of our portfolio. I would say we have lots of connections too in education and chronic disease, sort of childhood programs, aging-related programs, and so just again to emphasize this idea that there's a lot of talent and expertise out there, and so those are there to be tapped. And then finally, and more specific to opioid, I'm hoping that I can play a connecting role. So if there are specific programs that piqued your interest today, I'll happily sort of field those questions to the best that I can. But if I can't adequately answer them, I'm happy to serve as a liaison to those who might provide more information.
That's great. Thanks, Dr. Lindberg, for that. If there's any questions, either from legislators or from the audience, we have a little brief time here. There's one here, Michelle, if you want to get the microphone.
So I'll rephrase that, I think, just to make sure it was captured and that everyone heard. I think that the question, please correct me if I'm wrong, is really around work specific to youth and offered in educational settings like schools or colleges around the area of addiction, and whether there might be some unexpected side effects in giving youth information that would sort of expand their knowledge in a way that wasn't productive or sort of led them toward addiction rather than preventing it. Did I fairly capture that? So we do a fair amount of work that I didn't highlight here, but sort of school-based mental health work, which I think sort of touches on this a little bit and gets at substance abuse as well. And I don't think I think in cases where we're working with youth, and when I say we, I mean big we, not necessarily our evaluators, but the teams that we work with as well, there typically is a lot of thought that goes into making sure that they're developmentally appropriate as well as medically accurate. And so we wouldn't be giving information to kids who are young in a way that wasn't appropriate for their age group. I'm not sure that adequately.
Programs out there right now that we can look to as exemplary programs.
Oh, I see.
For university and high school.
For university and high schools. I think so. There's a program. There are a few. So the state, and not specific to opioids, but really looking at behavioral health. The State Department of Health Services and the Department of Public Instruction implement programs that really look at school-based mental health. And I will have to follow up with the specific names and examples, but I'd be happy to do that.
And I would like to just speak to whether kids are ready with the media talking about opioid addiction, other forms of addiction, primarily opioid addiction, all the time, everywhere. I don't think there's a kid who hasn't heard about that, and just not talking about it, I believe, can do more harm than good. My 8-year-old daughter can answer questions about that, and we haven't specifically even talked about that, which means she is exposed to it because it's everywhere out there. And certainly my 15-year-old son in high school is very knowledgeable about addiction, and I'm sometimes scared to even ask him what's happening there. I still do, but kids know. And I think that it's a mistake not to address it up front with them. In fact, National Institute on Drug Abuse has issued a curriculum for elementary school kids. So it is available online, last time I checked, but it's targeting 3rd through 5th grade. So it's age appropriate, but we start educating early to make sure we avoid huge problems in the future.
Time for one last question here.
Thank you. Thank you for your presentation, Dr. Lindberg. You had mentioned that, possibly you could comment on specific programs or get us information later. I'm wondering about what's happening at Wisconsin Indian Wellness Centers. So whether it's prevention work or treatment work, what is the Native American culture, our community doing?
Right. That's a great question. I will definitely follow up with a connection for you. But let me see, some of the work that's happening, the work that I know about is really in relation to this more on the treatment and diversion standpoint, and really looking to get folks who are suffering from addiction and interfacing with law enforcement for that reason, getting them access to treatment instead of sending them to prison. And that, the Tribal Wellness Court that's listed there, the Fond du Lac Drug Court, those are, or not Fond du Lac, rather. There's another one that just ended. But those are specific programs that are really specific and tailored to tribal communities.
Tribal Wellness Court, where is that?
This one, I believe, is in Menominee.
Menominee.
Yeah.
Okay.
All right, well, thanks, and sorry I don't have time for a couple more questions from the audience. Our final speaker today is Bree Dio, Research Coordinator at the UW School of Medicine and Public Health's Department of Family Medicine and Community Health. One of our current projects is working with Dr. Randy Brown and his team on the Screening and Trauma for Opioid Misuse Prevention, or STOMP study, funded by the Wisconsin Partnership Program. She's worked on a variety of projects for the School of Medicine since 2011, and is a certified clinical research coordinator and member of the Academy of Clinical Research Professionals. Thanks for being here today, and go ahead.
Thank you. So, like Sam said, the study that we're working on right now that I'm going to tell you about is the STOMP study, Screening and Trauma for Opioid Misuse Prevention. Dr. Randy Brown is the primary investigator on this study, and you'll see a whole list of names there. It kind of takes us a small army to get a study like this off the ground, as Dr. Zagorska already knows. So we're going to start out with a patient case. Dr. Brown is a primary care physician, and kind of one of the things that we're looking at is that we know that people don't go, they don't pick up heroin just one day. They don't just start injecting heroin. So what are the things that build people up in their addictions? And so in this patient case, it's a 27-year-old male with pain related to athletic injuries. One of his direct quotes was that he was taking a month's worth of Vicodin in 2 days. He was also using a lot of alcohol. He had a seizure related to his withdrawal, and after he was in a pretty intense treatment program, has been in sustained recovery for about 20 years. And the reason that I can tell you this, and that it's not a violation of patient privacy, is that this is a very public story. You guys probably already know this guy. That was Brett Favre. And what I'd like to point out about his case specifically is that all happened while he was in the NFL, while he was playing football for the Packers, and arguably during the peak of his career. That all happened right around 1996, when the NFL actually banned him from drinking alcohol. And he spent 46 days in a inpatient rehab facility in 1996. The very next year, he took the Green Bay Packers to the Super Bowl. His medical team is literally invested in his physical health, and watching him closely, and still he was able to escalate his opioid use to problematic levels. So kind of, how do we bring this to the rest of the world? I mean, we don't all have teams of physicians who are checking up with us every single day. I'm not going to spend a lot of time on this slide because we've already talked about the significance of the opioid problem in the United States, in Wisconsin, and specifically in Madison. The third point there is that workflows and interventions that prevent opioid-related harms, specifically with trauma victims, remain uninvestigated, or underinvestigated, I would say. Brett Favre didn't just start using 2 months or 1 month worth of Vicodin in 2 days just because he had some knee pain. He had a lot of like multiple injuries and injuries that were causing chronic pain. And so what we're investigating with STOMP is, what are these risk factors that take someone from an acute injury to chronic pain, or from acute injury where they're using what's supposed to be a week or two of opioid pain medication to 6 months of pain medication. What are the risk factors, both of the injury and of the person and of the medications maybe, that might predict prolonged opioid use? So we're addressing that in the study, and hoping to use those factors to develop a screening tool to predict that opioid risk after a traumatic injury. There's a model that exists now with alcohol use. If any of you have been in the emergency room in the last couple of years, they probably asked you about your alcohol use. And that's kind of similar to what we're doing here with opioids. It's hopefully will be a simple 3-question screener that we can use to get kind of sense for how at risk a patient might be to misuse their opioids. And we're also going to try throughout the short 3-year span of this study to pilot the implementation of the screening tool that we're trying to develop. This is a 3-year grant. It's funded by the Wisconsin Partnership Program, and it's going to take us 3 years to get to all this. So we're not going to answer any, we're not going to solve the opioid crisis in a day. We're not going to prevent people from becoming addicted to opioids in a day. I mean, it's going to take 3 years for us just to get the screener out. So this is a conversation we're going to be having for a while. Here's our investigative team, just to illustrate how many different perspectives we're taking with this study. There's all kinds of the takes that you can take on a problem, perspectives that you can look at a problem, and we've got all these partners in our study. So basically what we're going to do, our first 2 aims involve gaining information. The online survey, the summit, and the focus group were focused on trauma center staff, and these were available to trauma center staff and trauma coordinators from all level 1, 2, and 3 hospitals throughout Wisconsin. So we gained some perspective from them. We used the information that they gave us to put together a whole gamut of surveys that we are currently administering to. We've got 9 so far, 9 out of our 295 injury victims at the UW Hospital and Clinics Trauma Service. We'll be following up with these people for 6 months. What we're trying to do is gain some perspective on their injuries, using their injuries and their pain management through standardized questionnaires, medical record data, and public records. So it's this information that we're going to try to use to create some kind of screening tool. Our third aim is developing a protocol for implementing the screening tool. Who should be giving the screening tool? What's the best way to administer it? Should it be while people come in the ER? Should it be in primary care? Should it be administered by a physician? Should it be administered by a social worker? Can it be just a little questionnaire that people fill out on paper? So these are all things that we're trying to do in our third aim here, and that'll be during the 3rd year of our study. What we're kind of expecting at this point is that at week 4, this is 4 weeks after the patients are out of the hospital, we'll administer a standardized questionnaire called the Current Opioid Misuse Measure. What we're thinking is that the scores on this survey and the pain medication questionnaire will predict opioid misuse and use disorder at week 24. Now, the physicians in the audience are probably thinking that people aren't going to develop a use disorder, like a full-blown use disorder, at 24 weeks after they've started using opioids. But we do have a standardized screen that can help us catch misuse patterns before it becomes a diagnosable disorder. The other thing is that we've got some other measures, a quality of life measure. One of my favorites is the pain catastrophizing scale. And average daily opioid use can also, we're thinking, will also predict this misuse and use disorder at week 24. And we also have partnered with Gunderson in La Crosse, Medical College of Wisconsin, and Marshfield, the Marshfield Hospital, to do this implementation pilot for us. So we're going to be going to some of the other hospitals around the state to investigate our implementation. So some of the policy implications that my team kind of came up with is that, on the screen here, opioid therapies are necessary for treating pain. There's no doubt that opioids are addictive and that opioids can cause harms, but they also are one of the most powerful tools we have to help people heal from traumatic injury. And so what we're trying to do is, find a balance between adequately treating people's pain and trying to reduce the harms of the opioid. Second, questions like how prescribers can most effectively achieve this balance between risk and benefit still requires a lot of investigation. We still don't know all the answers. Third, and I think this is one of the most important ones I think that we're getting at with this study, is that pain management requires a lot of different types of care. And there's a lot of guidelines coming out favoring things like yoga, pain specialists, complementary medicine, mindfulness, in helping people not only recover from pain, but also to deal with the psychological stress that pain can cause. And so, all of these things help, but in order to really minimize the harm of opioid use, I think that all of these services need to be covered by public insurance, which is, I think we got a little ways to go there with that one. And also, there shouldn't be regulatory barriers or fiscal barriers for anyone obtaining or administering naloxone. And I think that Captain Nelson spoke to that earlier when he was talking about, not criminalizing people and, giving them a criminal record for having an opioid overdose, but to, help them get hooked up with services, all of which we think should be covered by public insurance. We've got a couple of resources. We've got a website up to keep people up to date with the progress of our study. We started recruitment on Valentine's Day, actually. We've got 9 patients that we're following so far, and our goal is to get that up to 295. So we'll keep updating our website. We've got a monthly newsletter that comes out just to keep up with what we're doing with this study. We've got an email address there, and if you're ever unfortunate enough to suffer a traumatic injury and find yourself an inpatient at the UW hospital, look us up and you could be part of our study.
Well, thanks for that, Bree. We have time for a couple questions before Rosa Rodriguez. We can start with you.
Hello, everyone. I'm Representative Jessie Rodriguez, and thank you for the information you just provided. It certainly made me think about certain things. I know people who live with pain, and they are under treatment, so they see a pain specialist, and so they are regulated. You talked about trauma. I guess my question is, how do you define trauma? Are you defining trauma as something that happens at one time and, there's a treatment for it? Or are we talking about people who probably will live with pain for the rest of their lives and have to, see a specialist and are under, and their medications are regulated?
Great. That's a great question. So at screening in our study, we're taking people who have just suffered a physical injury, a physical trauma, and then following them up for 6 months just to see how that progresses. So some people we expect will, once their ribs heal or their ankle heals or whatever, or their surgical wounds heal, they'll stop taking their opioids and then they'll go on. Some people probably will develop a chronic pain type of situation where they are having to maybe see a pain specialist or, see other practitioners for ongoing care for their pain. So these are all things that we're sort of keeping track of in our study. This study is sort of it's what we call an iterative study. So we don't really we're just watching, right? And so we're watching these patients just to see how they progress and keeping track of all that kind of information, to see if there's something that, like, at what point, do people start showing signs of risky opioid behavior or opioid harm, and that's what we're trying to look out for.
Representative Billings.
Thank you. And thank you for your study. I think this is going to be really interesting and very helpful. So when you're in this study, are you taking into account whether or not people have a warning from a doctor or a pharmacist or someone about the addictive qualities of opiates before they even start?
Yep.
Okay, great.
Yeah. We do access the Wisconsin Prescription Drug Monitoring Program. Yeah.
Yep.
So we do access the PDMP. Anyone who signs consent for our study, we'll look them up. We look up people in CCAP just to see if there's any warning signs there. We are excluding people from this study who do already have current opioid use disorder. So there's a screener that they'll go through. If they're already misusing opioids, then we won't follow them. We're taking people who don't have misuse behaviors and trying to see what factors lead to those.
I asked this question because I have a student in my district who told her story to me. She asked to meet with me and said I could share it with people. But when she was misusing opiates, had been prescribed opiates because of a burn. Her roommate was burned at the same time. They both were prescribed opiates. She was using hers and her roommate's to help her get to sleep at night. She was self-medicating with a drink and a pill. But she was warned not to take it on an empty stomach, but she wasn't warned of the addictive qualities of the medication. And she thought, well, a doctor prescribed it, so it must be safe, and I can, why can't I use it to help me during the stressful time, get to sleep at night? Used hers and then her roommates, and luckily went to the counseling center on campus where someone gave her a drug assessment, and she filled out everything she was taking. Like, this is nothing wrong with this. And the counselor was like, whoa, this is an issue. Do you know how incredibly addictive these drugs are? And she didn't have any idea. And I know there's a tension for physicians because they don't want to scare people away from using medication that they should be using. But I'd be interested to see how many people are not getting that warning. They're warned, don't take this on an empty stomach, but they're not warned of the incredibly addictive qualities.
Yeah, and that's a really good point. This study is observational, so we're not participating in care decisions or anything like that. And it's true. What's interesting about sleep is that patients will say, well, I can't sleep because I'm in pain. And so are they taking the opioid for sleep or for pain? So it kind of becomes fuzzy. So when I'm asking patients, are you using this medication for a reason that you did not discuss with your physician? They'll say, well, no, maybe, and we talk about it. Yeah, so it is. It's very interesting, and but yeah, we're not interacting with the prescribers on how they counsel their patients to use the opioids.
But you're tracking.
But we're tracking. We're tracking the use, but not necessarily the prescriber's counseling.
Oh, okay.
And that's probably all that we have time for today. If there are any additional questions or follow-up that you want to have with these projects or any other ways we can be of service through EBHPP, feel free to contact me. My email is up there on the screen. Thanks to everyone for being here today and for enduring the proverbial fire in a crowded room. Since the alarm was blaring while I was talking, I was quickly, again, thanks to our funders of the Wisconsin Partnership Program at ICTR and at the UW-Madison Chancellor's Office. If you haven't done so, please fill out your evaluation forms and leave them either with staff at the doors or on the tables on your way out. All materials and program video will be posted on our website. I think that the slides should be already up there. and the video should be up in the next several days. We also have find information on past briefings and upcoming briefings. We're looking to shoot for something late April, early May for our next briefing. Thanks to all our panelists here and to all of you in attendance. Again, we aim to strengthen the connection and discussion between the campus and the Capitol, and I think that today's briefing was a great example of that. So thank you very much and have a great day.